This is SG2 Perspectives, a conversation with industry experts and SG2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
So they're going to have to be really flexible and nimble over the summer. They may still have COVID patients. They may be trying to reactivate elective procedures. They may have to prepare for a second wave. And several of them have acknowledged that while all that's going on, the activity in the last 2 to 3 months has fundamentally changed their long-term outlook. And they know they have to be prepared for those changes and to capitalize on that opportunity.
Welcome to SG2 Perspectives. I'm your host, Trevor Drin. And this will be our 4th episode talking about how health systems are responding to COVID-19. Today I had to talk with Bill Woodson and Jennifer O'Connor, who are leading so much of our work with health system strategy leaders regarding COVID. And one thing I've learned from you two is that strategy teams are kind of dividing their work into a few timeframes, and we'll touch on all these timeframes today. The surge phase, certainly the scariest and causing huge operational changes, followed by reactivation planning that's probably taking the majority of planning team's time right now, and then trying to think of down the road, imagining what the new normal or at least the short-term normal might look like. So Bill and Jennifer, and you talked to so many of our members, even just in the last 2 weeks, what were some of the themes, and were there any surprising questions or comments? Bill, why don't you start?
Yeah, I'll set up a few themes and we'll see where we go from there. The first is clearly in certain markets in the country, they have and are still experiencing a COVID surge, and their operational and clinical reality is far different from what's going on in other markets. So Northeast, New Orleans, and we've talked to systems in both those markets, it's a very different world. In many other parts of the country, operationally, they're ready to go. They've kind of emptied their hospitals and shut down their revenue streams to plan and prepare for a COVID surge that has yet to occur. So there is an anxious waiting game about, will this happen to us, or is it going to be a very kind of a flat tail of the curves that have been happening elsewhere? So there's that division across the country. And then right after that, thematically, you brought up the key one for us, and we'll get back to the moment, which is the initial planning for financial stability, recovery, re-entry, and that work focused very much on elective procedures. And then a couple other themes are really starting to pay attention to physician finances, the fragility of independent practices in different markets. That's almost everywhere in the country. And then at the beginning of a conversation about patient attitudes, their willingness to seek healthcare over the next couple of months. And that's a big unknown across the country right now.
Yeah, and Bill, I'd just add in there, I think what's been amazing about these conversations, and you hit on this, the variation that we've seen, both in terms of geography and what people are experiencing. Some people are smack in the middle of the surge, and some are still waiting anxiously. And in some cases, they're starting to think there's not much of one coming. So that's very different. But some of the shifts in volume in folks' business has been phenomenal, right? We're hearing ambulatory volumes down anywhere from 50 to 90%. That's driving that financial crisis that you're hearing about, both for physicians and hospitals. And on the flip side, ambulatory virtual visit volume is just through the roof. We're hearing multiples of anywhere from 4 to 10x, right? We talked with a system in the South, and they said last year we didn't do 4,000 direct-to-consumer virtual visits all year, and we are literally now doing 4,000 a day. So just the magnitude of change that systems are going through in the midst of this pandemic has been pretty amazing to hear.
What that tells us, Jennifer, and it's early, is that there is a wave of innovation that has moved through the industry in just a matter of weeks. Disruption, things that we've long talked about have actually had to occur. And our members, some of them have already started for that planning, which is how do we capture what we did well, what we should continue operationally, clinically, and even in how we've organized the work that we do every day as a team.
Yeah, I think that's the thing that's been maybe surprising, although it's heartwarming, right? People question whether healthcare could really disrupt itself and really be innovative. And this crisis has forced us to do it. It's allowed us to do it. And I think we've both been impressed with the number of people who are committed to not letting this crisis go to waste. They are going to use it and leverage it to long-term good effect across their organization. And that's the kind of response that you'd certainly hope for and that healthcare has been known for.
Great stories. We'll spend most of today talking about what comes next with COVID and what most planning teams are focusing most of their time on, and that's reactivation. But first, Jennifer, can you talk about how you were working with members using our surge demand calculator to do some of the tough surge planning work?
Yeah, it's been great. We've seen members in all those different geographies across the country using the surge calculator to get a handle on their bed needs and their vent needs. For those who are in the thick of it, it feeds their staffing and PPE burn calculators. So it's all important work coinciding with their command center, and it's allowed them to really add another facet of data into their modeling. And at that point, when you're in the middle of that, the more data you can get, the more scenarios you can run, the more projections you have, the better prepared you are. That's the name of the game, right? And so it's great that we can help them do that. The other thing that happens is the curve gets pushed out. The timing shifts. That's a bit of a head scratcher for folks. We'd seen in geographies like New York, the peak came and it came fast. And that's not the case for all places across the US. And so folks have had to adjust their planning for the reality that if you flatten the curve, that's a good thing. It does mean a long tail and a sort of set number of COVID positive cases over a really long time frame. And that starts to get tricky when you think about reactivation. So just getting people used to the numbers and the variation you see, it's been a journey, but a good one.
And Bill, what do teams look like that are doing this work? We've heard of some of the obvious reorganizations like folks shifting into more operational roles, but who are the teams leading reactivation planning and how are they going about that work?
Yeah, there are two different parts to this. There's the part that Jennifer alluded to. There's the command center group. Often that's a group of the most senior executives with designated clinical leaders purely on the surge. What we've started to engage with are teams that comprise lots of other areas of the health system, going through a view of what recovery will need to look like. That starts with one group, and representation is broad. In some systems, it is anchored by the chief strategy officer or those who are not as directly involved in patient care with a direct link to the operations people, especially the physician governance part of the organization. Let's add on to that. There could be multiple teams now going in recovery planning. So there's a group kind of already at work about bringing back in elective cases. There are others that are focused on the next phase of care delivery, clinical operations, carrying forward other innovations in the systems, a reevaluation of M&A candidates or opportunities, and outreach to the physician marketplace, and depending on the market, other groups as well. So most organizations are taking a multifaceted view of the near future and even the next 12 to 18 months.
Bill, I think it's been interesting, again, given that variation in geography, we've seen some of our clients where the search has been big, acknowledge they're going to continue to run the command center and spin up this reactivation task force and run them in tandem for as long as 18 months in some cases. And then there's been other places where they spun up the command center, planned for a surge. It's not going to be nearly what they originally projected. And so they're actually talking about winding down the command center and replacing that activity with reactivation. And so there's differences in terms of resources people have as they look to approach that.
Yeah, and similarly, Jennifer, for those organizations that are really in the surge right now, there are some traditional competitors coming together to try to do more regional level planning. And I know we're participating with the group in Chicago because this is SG2's home and backyard. But what are we seeing in other places? Are we seeing that be successful? What are some of the outputs? Could this lead to hopefully more collaboration in the future?
Yeah, I think, we'd like to think the answer to that is yes, right? And you've certainly seen in some states, particularly where there's been a proactive governor, they've garnered leadership from health systems across the state and really looked to them along with their public health officials and scientists as the anchor for making smart decisions about what needs to be done for safety and eventually reopening the state. So you've seen some good work in some cases, but it's been interesting as we've talked to folks behind the scene. They acknowledge it wasn't easy. It has opened doors. I think there'll be ongoing conversations. I don't know that we know as folks look for the reactivation and frankly, just the reality of finances. I don't think we know how that's going to go in terms of continuing to work together through reactivation. It makes a lot of sense that people would look at patient need across the market and work together to reopen those ambulatory procedures. But the realities of the financial situation could make that tough. I think on the clinical side, it's been a little easier. We've certainly seen good examples as markets where they've designated, say, a convention center for the overflow, hospitals working together, staffing those together, kind of figuring that out, sharing information. We've seen lots of good examples there. I don't know, Bill, I'm curious your thoughts on how you think that works as we head into reactivation.
2 parts, maybe 3 parts to that answer. Moving forward, there's clearly going to be a need for health systems to cooperate with the public health infrastructure on getting back to whatever normal is. And that will include how patients are tested, how the workforce is tested for the virus, antibody testing, point of care testing. And then that connects to surveillance and contact tracing in the broader environment, depending what state we're talking about. That's going to require participation from everybody. There's another piece where there's been great sharing of resources, not only staff, but equipment, supplies, PPE. That may continue because we foresee continued supply chain strains over the next several months across the country. But having said that, the systems that are already digging into recovery, reactivation, finding their way back to elective procedures, they're expecting fierce competition for everything that's going to happen in that space.
And Bill, moving forward in our timeline, how are these new planning teams tackling the work around restarting elective procedures?
Yeah, right now it is building the list of needs to truly begin a restart in earnest. And that means there is a nexus of planning and clinical operations. There's a view of first the epidemiology in the market. We'll start there. When can we actually go back to treating patients on a procedural basis? And there are urgent cases, emergent cases showing up today across the country. Those will happen. But after that, it is a real exercise in, all right, where are we going to treat these patients? Which procedures will come into the system first? Who's going to deliver the procedures? Not only the surgeons, but the anesthesiologists, the rest of the workforce. Will we have sufficient PPE, other supplies and equipment? Can we run on extended hours during the week? And can we do procedures on the weekend? Can we dedicate some aspect of our space on campus or in an ambulatory surgery center just for procedures? And it kind of goes from there. So this is a multivariable problem-solving exercise, and it begins with patient needs, and then it goes from there. And that's why there's lots of interest, investigation, learnings about what it's going to take for workers to feel safe and what it's going to take for patients to feel safe. If they've been putting off something, they're going to think twice about coming back into a hospital setting or a procedure setting.
These really tough planning exercises will hopefully have a residual benefit, right?
Let me add to this, Trevor, a little bit, which is we had one chief financial officer described this as maybe it's an exercise not unlike opening a new hospital, a new facility. All the challenges you have with that, he was describing that they expect to experience that as they ramp up doing procedures again, all the operational complexities and the missteps, figuring out scheduling for anew, which was never easy in the first place. And there's a financial side, so an expectation that health systems might not get payment for weeks or months from some of the payers, or at least there could be some challenges with pre-authorization for patients. It's that degree of the challenge that awaits us. Meanwhile, there will be competitors that are just ambulatory surgery centers and markets that will advertise that they're ready to go, and they can make their spaces potentially more appealing to patients and staff. That will become attractive in some markets.
Bill, say a little bit more about that. I know that a big chunk of the conversation you've had talked about both the financial impact of health systems, and we talked about it with Steve LaFar a couple of weeks ago, but I'm sure a little bit's changed in 2 weeks. Can you talk about both the revenue and what you're hearing on the cost side?
It's the magnitude of what's hit that's so startling. And as we've talked to some systems across the country, we're having conversations about hundreds of millions of dollars that have been taken off the table. And now it's a path to find a way back to that. One system has mentioned just in the last few weeks, they've lost $100 million worth of business. Another system mentioned, and it's a big one, that as they've reforecasted their budget for a year, they expect to be down $3 billion, the loss to be $3 billion. So they're trying to find a way back to 900 million. If that sounds fun, it probably won't be. And that tells us there's going to be a set of revenue solutions to go after the business in a really intelligent way to get it back in the door. But there will be a lot of work on the cost side as well. And most of that cost work was underway to one extent or another. Now it will accelerate because health systems will need to find tens of millions of dollars. And maybe that's the other opportunity. Jennifer kind of alluded to this before. There's still, despite all the work that's gone on over, the last decade, health systems still struggle with consistent formularies, overlapping clinical pathways, all sorts of things that they've done with physician preference. There are challenges that have been difficult to take on that now may be available to take on the cost savings that are going to be needed to make systems financially viable. We know that there are systems that won't make it. We're optimistic that there's going to be some policy relief there, meaning some more dollars from the federal government. And that goes hand in hand with what's going on the physician side, where revenue may be down 70 to 80% in some physician practices. There will be independent practices that have to close or that just can't make it. That's a challenge and an opportunity for the health systems across the country.
Yep. Bill, as we've been talking to folks, we've mentioned it a couple of times, but just the order of magnitude on this one is really kind of mind-boggling. I think universally, we've heard health systems say they went to an immediate cap freeze. For many of them, that was all expenses frozen for at least a week while they got their arms around a more centralized process so they could better manage it going forward. For most of them, it's a long-term freeze on CapEx, and we're hearing folks say they're trying to whittle down what was perhaps a large planned investment this year. They can't get all of it back. Some of it's already too far down the road, but anywhere from a third to 90%, they're trying to hang on to help close the gap, even with the stimulus money. So they've already worked the stimulus money into the model, and they're still at the losses that you've referenced, right? We're hearing people say they're at a burn rate of 120 million per month. These are huge numbers that get you to that end of year hundreds of millions or billions of dollars of losses. Across the board, I think we've also heard folks say that if they haven't already put a hiring freeze on, they expect to do that. And of course, it's been in the news. We have some systems that have already moved to a furlough and are starting to look at layoffs. And that's, really an indication of what we've known, that there's some haves and some have-nots in healthcare, and those who are in better financial position have been able to stave off decisions like furloughs and layoffs, although even those systems, and we talked to some that are AA rated, 400 days cash on hand, right? They started in a really good place. And even they would admit that they have looked into when they'll need to tap lines of credit, and that while they don't want to put any jobs of employees at risk, they will make that decision perhaps in a few months, right? So they don't have to make it today, but they will give themselves the ability to relook at that. And we may get there. So it's a tough financial picture for many of them, and getting organized and getting ready to bring patients back in safely and restarting that economic engine is something that they are all very focused on.
Jennifer, what about those systems that are in markets that just haven't quite surged yet? To me, that would be almost more uncertain and scarier, at least from a planning and modeling perspective. Talk about the work they're doing and how some of those calculations may be different for organizations in a market that hasn't surged yet.
Yeah, I think it's a tricky line that they're walking, right? Because on one hand, they haven't surged. Maybe the curve is flatter. Maybe it's been pushed out. And that's a good thing, right? They've got more time to plan and get prepared and try to get those PPE supplies that they need. I think the reality is, as we talk to folks, though, and we talked with some folks in the Southeast where they said they're looking at a peak in maybe mid-May, right? That's still a couple of weeks out. There's a point at which it creates this pressure, which is, when is this coming? Because we're still sitting here with no elective and ambulatory volumes coming in. And so in some ways, it might be worse because they've taken the proactive measures that needed to be taken, in all fairness, to keep people safe, but it creates an even bigger financial strain for them. And so you'll hear people in those geographies talk about the pressure they're getting from businesses and even local government saying, when can we reopen? We have to restart this engine. Can we sort of move past this idea of a crisis? And in some places, they're actually running the numbers and saying, even when it peaks, they will absolutely have inpatient capacity to manage the numbers they're now seeing in the model. So then it really becomes a question around PPE and testing in terms of, letting them feel confident in making some of those moves. But yeah, I think for some of them, that kind of sitting and waiting is a really tough place to be.
Okay, with that in mind, this episode is going to be released on April 22nd. So thinking about what at least the short-term normal might look like, what do we think May and June is going to look like across the country?
I'll take a shot at that. There will be some markets that start to relax social distancing, but that will just require us to accelerate what we need to do with testing of patients and employees, let alone the general population. So health systems are already getting a crash course in epidemiology and public health infrastructure. That will continue, and that adds to the uncertainty. In our membership, that raises an issue of mission and being an ethical participant in healthcare right now. Hey, we would love to resume business as normal, but what's the right thing to do for our patients and our workforce to keep them safe? That's going to be a difficult balancing act. And what we'll have to live with is that the virus will still be present in every community in the country. Perhaps we'll get some good news on therapeutics in the next few weeks that will help this. And it could be that the supply chain has kind of restarted itself and we now have new ventilators coming into the system. There could be some easing, but it still feels like we'll be wrestling with a level of uncertainty about timing and recovery that will be extremely frustrating.
Yeah, I think we're going to continue to see this variation, right? We talked to some folks in New York, and they are obviously on the kind of the back end of their peak, but they expect to have over 300 dedicated COVID inpatient beds for the next 18 months. So they're going to continue to sort of live in that world while they try to bring some other clinical activities back to normal. For others, where the surge was much smaller, we're definitely hearing many of them targeting potentially late May, but lots of folks saying June is what they're putting in the models right now in terms of a concerted effort to bring ambulatory volumes back. And so should be a lot of execution on those reactivation plans that they've been working on, assuming things kind of stay where they are. And then, we've been hearing folks acknowledge that they'll have to prepare, this is some of the uncertainty Bill was talking about before, for a potential second wave. So some people will actually have to reactivate or could have to reactivate command centers. So they're going to have to be really flexible and nimble over the summer. They may still have COVID patients. They may be trying to reactivate elective procedures. They may have to prepare for a second wave. And several of them have acknowledged that while all that's going on, the activity in the last 2 to 3 months has fundamentally changed their long-term outlook. And they know they have to be prepared for those changes and to capitalize on that opportunity. Many of them believe virtual health is here to stay. How can they really appropriately support that going forward? Several of them have said, we're going to pull out our 5-year strategic plan, probably when things slow down a little bit. So late July, August, instead of vacation, we're going to redo our strategic plan. So I think there's going to be a real mix of activity that we're going to see.
Trevor, there are 2 areas of clinical care that we know have pent-up demand that haven't got as much attention yet. One is behavioral health. We know there's going to be all sorts of needs across communities across the country, and a lot is being done through telehealth today and successfully, but there's more out there. The second area is chronic disease management, and the headlines have been about, hey, we're not seeing heart attacks and strokes in the emergency department. That also tells us that there's a huge population of people with diabetes, pulmonary disease, congestive heart failure that have not been actively in the healthcare system that are going to need help, care management, get back on their meds. That's an enormous need that looms out there for most health systems as well.
Yeah, I'm excited. And in the coming weeks, we're going to have that conversation with several of our service line leads to get a little bit more in the weeds and start to think about some of those downstream impacts on different disease types and cohorts of patients. So thanks for teeing that up. That's great. Thank you both. Another really strong deep dive. We see the focus shifting a little bit each week, and it seems we're getting to a place where health systems and planning teams can start to see, I'm not going to say a light at the end of the tunnel, but can start to see what's next. And at least the picture's clarifying. So thanks for helping further clarify that picture and share your insights. Look forward to talking to you again soon. This has been another great episode of SG2 Perspectives, where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you. SG2 revolutionized healthcare demand forecasting with the Impact of Change forecast, and today we're the industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks so much for listening, and we'll see you again soon.